Good afternoon, everyone that's coming to this session on the recording. If you would mind, go ahead and sign in using the attendance link. This is up to date, so just so we can monitor all those that are attending, and so we can keep this thing in the future as well. And I'll try to come back to this link in the end if you happen to forget or you just don't have your phone up right now, but let's keep moving. Okay, so this PowerPoint is going to be going over high-risk intrapartum. So we're talking about the kind of the things that could be kind of troubling during the laboring process, things like that. All right, just to kind of put it out there, second exam is coming up. I would appreciate it if you guys start getting prepared early. This one is a little bit harder than the first exam. She may have told you that, but really just try your best. And here's some tips that I thought that would help would be to look over the PowerPoint slides, and not only for our lecture, but also SI. It's important to know that, just to look over both. I wouldn't really put all emphasis on one thing. You have a lot of time, and I think you can really do it. If there's something you're struggling with, please handwrite that. I can't stress that enough, and then lastly, the textbook, if there's something you're confused on, you just want to know the background of it, you want to know the patho behind it, would just really help a lot. The other thing I would recommend to do is to come to our exam review that I'll be having next Wednesday at 6 p.m. And moving forward, I'm going to try to have our sessions. I know we've both been really busy with clinical, and I would like to maybe move them to later on Wednesdays. So maybe if we get a good attendance, we can keep doing that on Wednesdays at 6 p.m. That would really help a lot. I do apologize if my voice is a bit scratchy today. Okay, starting off the review of our parameters. We've already kind of talked about this in our earlier sessions, but just know the words. I wouldn't want you guys to get a question wrong just because you aren't sure of the wording. So around 40 weeks, but we do have, of course, the 37 through 38 weeks, all the way up till 39 weeks. That's going to be early term. 39 weeks through the end of the 40th week is going to be full term. And then after that, you're going into late term and then post term. Of course, we do have preterm labor, PTL. Okay. All right, pregnancy loss. A cause of this, less than 12 weeks. That's going to be our verbiage for this. We have a spontaneous abortion due to a hormonal imbalance or a genetic abnormality with our baby. This could be chromosomal. Example, Sean Johnson. 12 to 20 weeks, we could have a incompetent cervix, which we would do a cerclage to try to prevent that. We could also have just preterm labor between 20 and 37 weeks. Understand the wording. SAB, spontaneous abortion, that's often called a miscarriage in layman's terms. And then we also have a therapeutic abortion, something that is elective, okay? Repeated miscarriages warrant further investigation. All right, we do have an incompetent cervix right here. Patho, painless cervical effacement and dilation. That is not associated with a contraction, usually occurring in our second trimester. We have a congenital, we have acquired. That could be caused because of trauma. Because of trauma, we have multiple therapeutic abortions. We have LEEP procedures, and we also have any type of manipulation of our cervix. With hormonal, we have DES. This is kind of a synthetic of our estrogen being researched, or a lack of progesterone. Signs and symptoms of this would be like you feels like something's coming out, but it's painless, and then the membranes are just bulging through. Management of this would be to attempt to deliver a viable baby. So we're going to do full bed rest at the hospital, maintain them in a Trendelenburg position until delivery. We could also try to do a cerclage, which is we're going to kind of repair the cervix in a way to stop it from, widening. Next is our PROM, premature rupture of membranes. Just remember, this is membranes that are rupturing too early. They should not rupture before 37 weeks. Risk factors: hypertension, smoking, or just a prehistory of PROM itself again. With an assessment, we have a presence of the pooling fluid. We're going to do a nitrazine test on them. They could have some color, consistency, and odor of amniotic fluid. Ferning amniotic fluid has lots of sodium. Maternal vital signs, fetal monitoring. What's the first sign of infection? This is going to be present with tachycardia of our fetus and also a maternal fever, okay? We do not want infection occurring once their membranes do rupture, okay? Management, we're going to do, of course, we're just preventing infection again. PROM does increase the risk. We're going to avoid vaginal exams unless she's in labor, okay? Every time you kind of, touch something, you have a risk. Even if you wash your hands, you still have a risk of kind of spreading infection. Once membranes have ruptured, monitor temps every 2 to 4 hours. And we're giving a med in this. We're going to be giving betamethasone, also called celestone, to stimulate the fetal long maturity. This is kind of a steroid. That's kind of what it's doing. Antibiotics if needed. Okay, now PTL, premature labor. Anything before 37 weeks, the cervix is dilated. We have risk factors of this. We have multiple births, polyhydramnios, hormonal imbalance, history of preterm labor, dehydration, adolescence. So if the mother's an adolescent, we have young maternal age. Also, they may have some prostaglandins involved in the inflammation. They could have a UTI that does cause preterm labor. They could have the flu. They could have just a bacterial infection, or they could have an STI. An assessment of this would be painful menstrual light cramps. They're going to have a dull backache, pelvic pressure or heaviness, leaking of fluid from the vagina, uterine contractions. They can have a change in character or the amount of vaginal fluid present. And we're doing a test. This is called, we've already talked about this last week. We're doing the FFN test, the fetal fibronectin test. This kind of observes the glue that is present during pregnancy. This attaches to the amniotic sac. The fluid-filled membrane that cushions your baby in your uterus to the lining of the uterus. A negative predicts a good value. A positive is bad, but remember, we could have lots of false positives as well. We're going to do some management of preterm labor. We're going to keep them in as long as possible. We're going to ensure there's no underlying infection. We're going to keep our mom hydrated. A healthy mom, healthy baby, monitoring them both. Prevention, we're going to screen for infections. We're going to diagnose and treat them early. We're going to do a urine sample every single visit to monitor for UTIs. We're giving progesterone, cerclage, educate mom on proper nutrition, and we're going to really educate them on warning signs and risky behaviors, okay? We have some meds here for management of preterm labor. We have some tocolytics right here. We have some Utapar, Brethine, also called terbutaline. Please know those terms. Know that she could give you either name, beta mimetics, dilates the bronchial vessels to help them breathe. This can be given PO, sub-Q, and IV. This is going to relax our uterus, increases heart rate in mom and baby. It's not common to have cause cardiac incidents, CI in cardiac patients, not for long-term use. I'm going to pause right here so I can get a sip of some water. All right, next is going to be mag sulfate. We do have some, remember, this is used as a CNS depressant and as a tocolytic, okay? This is going to relax our uterus without cardiac side defects. We could have some side effects of this. We could have drowsy, lethargy, headache, nausea. We could, here in this book, it says a common side effect of mag sulfate is lethargy, heat sensation, respiratory depression, decreased reflexes, and cardiac arrest if they have a high serum level. Nursing concerns for this, we're going to assess the respiratory rate. assess their dependent reflexes and hourly urinary output. We're going to also monitor their levels as well for magnesium. Given to prevent seizures for our preeclamptic patients, we're not giving this IV. We're doing, of course, the 46 grams loading, 1 to 2 grams every few hours. Know the difference between these levels. We've already talked about that with the magnesium levels. Okay, too much, we're going to have diminished reflexes, but also they have respiratory arrest as well. We're going to want to give them enough to stop the labor, but not too much to stop the breathing. We're usually inserting a Foley due to the depressant side effect. We don't want them to be moving. This is also going to affect their blood sugar as well. Maternal and fetal vital signs should be monitored during this. Also, the reflexes in their eye and nose, like I already said. Kidneys are metabolizing this drug, so a decreased output indicates an increased level of the drug. Worsening preeclampsia causes decreased urine output. Calcium channel blockers are here as well. A med for this would be nifepidine. It's spelled Nifedipine. This is used as a tocolytic. A major side effect of this would be a headache, dysrhythmias, congestive heart failure, peripheral edema, flushing, and hypotension. So it's important that we monitor their blood pressures, their breath sounds, and intake and output. Long-term use for calcium channel blocker, premature closure of the ductus arteriosus. This sends blood to the aorta due to high resistance in the lungs. And of course, we have betamethasone, celestone. This is that, we've already talked about that. That's the fetal long maturity steroid. Goal is 2 doses, 12 to 24 hours apart. Here we have the type and the purpose. It's a corticosteroid. It stimulates fetal long maturity by stimulating the surfactant production. We have, for the major side effects, increased risk of infection and poor wound healing. This could produce hypoglycemia, increased risk of pulmonary edema when given with a beta adrenergic agent. Okay, 3rd trimester bleeding. I tried to kind of put what I thought about whenever I went over this stuff. So we have placenta previa and placenta abruption. Let's come to the patho of each. With a placenta abruption, it's the separation of the placenta from the uterus. Think of it as the top of the uterus, okay? So we're going to have a different color of bleeding from coming up there. We're going to have that dark red bleeding. Oftentimes, blood will even get trapped there, so sometimes you might not even see the blood. With the placenta previa, we have what the placenta prematurely separates, and it's the first thing that you kind of see. You're seeing this before the baby. It's very painless. It's bright red bleeding, and this is the definite C-section. Well, both of these are C-sections, but let's go back into abruption. For our risk factors, we have advanced maternal age, trauma or vasoconstriction drugs, hypertension, diabetes mellitus. This is painful dark red bleeding. So I thought about it as abruption. Think of the BR for kind of a brown color bleeding. And for the B, think of a bad throbbing pain, okay? Signs of hypovolemic shock due to bleeding at the top of the uterus. You'll see dark red blood bleeding. Okay, bleeding at the bottom of the uterus, you'll see dark red blood. Bleeding at the top of the uterus, blood will get trapped and you won't see blood. Signs and symptoms of abruption with no bleeding, blood is trapped. We're going to have a decreased fetal heart rate, board-like abdomen, and it's going to be difficult to palpate their uterus. Okay, for management, we're going to try to increase perfusion. We're going to monitor mom and baby. We're giving fluids, oxygen, and turning mom on their left side. And I believe this is going into our next slide as well. So we'll kind of talk a little bit more on that slide as well. With a placenta previa, this is going to be painless, bright red bleeding. We're going to be doing an ultrasound to confirm. This is a definite C-section. We're going to be doing an incision to avoid cutting the placenta. We're going to monitor blood loss for the baby, for the mom, and we're going to put the baby and mom on the monitor. We're giving IV fluids because they're losing blood, and then we're going to avoid vaginal exams for this. Okay, so we have a lot to talk about on this slide. I believe something like this will be on your exam 2 prep sheet. So just, if you'd like to pause the video, write all this down, and then kind of listen to it later. But I do have some stuff here that I think would help a lot. Okay, so we've already talked about previa and abruption. Look at their definitions. Talk about the risk factors. What their signs and symptoms, that's really important, and knowing what to do with the management. Okay, that's just what I recommend. With a velamentous insertion, the vessels of the umbilical cord divide some distance from the placenta and the placental membranes. Risk factors of this: multiple babies or a lack of Warden's jelly. Signs and symptoms of this are bleeding, maternal hemorrhage, fetal stress, non-reassuring fetal heart tones. For management, examine the placenta. Be aware of unusual bleeding, reposition. Placenta accreta, and I do have a slide on this with the different ones later. The chronic villi is attached directly to the myometrium of the uterus. Risk would be history of C-section. Signs and symptoms of this would be maternal hemorrhage, failure of the placenta to separate following birth of the infant, and a management would be a hysterectomy. But what I would really focus on this would be the definition of this. Know the difference between all of the three different, what we'll talk about later, okay? With a prolapse cord, I do have this marked on this page, so I'll kind of read it from here, and then just go off the slide as well, okay? So a cause of a prolapse umbilical cord is the fetus is not firmly engaged, allowing room for the cord to move beyond prolapse or alongside presenting part. Contributing factors of this would be a rupture membranes before the engagement of the presenting part. You could have a small fetus. The breech presentation is often associated with it as well. A multifetal pregnancy or a transverse lie. Okay, assessment and nursing diagnosis. Identify the client at risk for prolapse cord. Keep women with ruptured membranes in a horizontal position. Of course, they're having different NANDAs here, but that's not really that important. So for a priority intervention, kind of actions to really relieve pressure on the cord and restore fetal oxygenation. So we're going to be putting them in a knee chest position. We're also going to be putting them in a Trendelenburg position as well. We're going to perform still vaginal exam, pushing the fetal presenting part upward with the fingers to relieve the pressure on the cord, okay? Because if that cord is being kind of squeezing, there's really no oxygen kind of getting through. So we want to relieve the pressure off the cord. If the cord protrudes through the vagina, determine the pulsation is present and apply sterile saline soaked dressing to prevent drying. Okay, the reason to that is kind of essentially once we get into newborn, we're talking about what happens whenever that when it's exposed to air. When it's exposed to air, it'll constrict, and it's kind of what it does naturally. Okay, so just know that you do not want it to dry. We're going to be giving oxygen by face mask at 8 to 10 liters per minute. For evaluation, fetal heart rate remains within normal range. Fetus is safely delivered, and the client and family verbalize understanding of the implications of a prolapsed umbilical cord and the need for emergency management, okay? I would imagine that whenever Professor Harold talks to you guys about this, that she kind of talked about what happens whenever this occurs. You know, she'll probably say the story of them rushing down the hallway. One person is literally there, just their job for the rest of until they get into the operating room or emergency delivery, is to just maintain that cord, make sure it's not compressed, okay? Alrighty, next is uterine rupture. This is a non-surgical disruption of the uterine cavity, kind of a tearing feeling. We've talked about the risks of this with the C-section, knowing that if they have the the classic version of the C-section, that's where we're getting that risk from. Okay, risk factors this are uterine manipulation, operative vaginal delivery, abdominal trauma, or less than 18 months between babies, or maybe a previous C-section as well. So we're going the bleeding. I'm going to read the signs and symptoms off this slide that I found in the book that I have. All right, a uterine rupture. Most common causes or a separation of the scar from a previous classical C-section, uterine trauma, intense uterine contractions, overstimulation of labor with oxytocin, so kind of too much of that in there. A difficult forceps-assisted birth, external cephalic or internal version. Risk factors: multiparity, overdistension of the uterus, multifetal pregnancy, malpresentation, and a previous uterine surgery. The types, not really need to know that for this, but kind of the nursing assessments, the signs and symptoms of this may be silent or dramatic. We could have sudden, sharp lower abdominal pain, a tearing sensation, signs of shock, no more contractions, fetal heart rate ceases, the blood loss is often concealed, or the fetal hearts may be easily palpated. Fetal parts may be easily palpated through the abdominal wall. We're going to, that's pretty much what that is there. Yeah. Yeah, that's it. Okay. Moving forward, we're monitoring vital signs doing the Leopold's maneuver, a C-section, blood type, cross match. Okay, multiple gestations. This is, twins, things like that. We do have monozygotic and dizygotic, fraternal twins and identical twins. Two separate eggs, fraternal. All right. For the effects this can have on our fetus and our neonate, if it's one placenta, so it's monozygotic, we're going to be having, we could have TTS, twin to twin transfusion syndrome, where they're kind of, one's taking all the food, things like that. We have fraternal twins do better due to having their own placenta. That's what I was personally when I'm a twin. Increased risk for prematurity, fetal abnormalities. We have artery to artery anastomosis of placentas, the TTTS causing polycythemia in one and anemia, intrauterine growth retardation in the other, means they're really, really small. We have effects on the mom. This could have more edema, more weight gain, increased risk for preterm labor, risk for PIH, anemia, placenta previa, hydramnios, and abortion. We have a potential labor complications, maybe a uterine dysfunction due to overstretching, abnormal presentations. They could have a breach. Then we would need a C-section. We could also have a placental abruption possible after the first twin. Must plan ahead. You need two of everything. If you have more than two fetuses, we're doing a C-section. Occasional twins are not diagnosed until delivery, often, sometimes. And this can, of course, cause emotional and financial stress. I know I was personally C-section, but I can't imagine them doing it vaginal. We have these fluid abnormalities. The one thing I'd recommend is no poly and ollie. Poly, think of it a lot more. Ollie, think about less. That's what I would say. 2,000 milliliters for the poly. Ollie is less than 500 milliliters of our amniotic fluid. Okay, if they're having a lot, and this is what we're kind of talking about, bringing it all together from what was talked about within the first few days of class for Professor Harrell's class. If they're having a lot of amniotic fluid, we have possible things of neurotube defects. We could have a cleft lip, an esophageal fistula, or anything that prevents swallowing of the amniotic fluid. Whenever we're having, that's for the risk factors. Okay. For the fetal complications, we have uterus stretch. We cover sudden inflation from the rupture of membranes. The care for this would be a fennel height. It's going to be off. The uterus is bigger than it should be. We're using uterine stimulants to measure fluid pockets and RO defects. We're monitoring the vital signs and symptoms of our embolism, oxygen for spontaneous abortion. Shortness of breath. And we're, of course, kind of trying to remove the fluid with the amniocentesis. And the flip side, having not a lot of amniotic fluid, a risk factor is kidney problems or placental problems, okay? Not enough fluid to the abnormal kidney function, variable decelerations, webbing, contractures, poor blood oxygen flow to the babies. They could aspirate, increased risk for cord compression as well. We're going to be doing an amnio infusion, so the opposite. We're going to be putting in amniotic fluid and also giving some antibiotics. We're going to be measuring the fluid pockets. When you put fluid in, you want to make sure fluid is coming out to prevent a uterine rupture. Okay, now going into labor complications. Dystocia, an abnormal labor pattern. It's defined as a rate of cervical dilation less than 0.5 centimeters per hour over 4 hours during the active stage of labor, or less than 1 centimeter per hour of fetal descent during the second stage of labor. And I have some more stuff here. Dystocia is often called a difficult labor. We have two different types. We have, and I'll go into the next slide for that. So we have hypertonic uterine dysfunction. We have kind of often called tachysystole, and excessive and frequency and duration with a diminished interval between more than 5 contractions in 10 minutes. Poor relaxation, knowing that during a contraction, the oxygen levels getting to our baby is often low. Excuse me, I need some water. Okay, contractions are too fast or too long with no rest. It's not filling with blood, not good for the baby. Contractions for too long with no rest is very dangerous. Causes of this would be cocaine use, Pitocin-induced and abruption. But I have right here as well that maternal risks are prolonged or non-progressive labor, pain, and fatigue. Okay, so for the fetal risk of this, we've already kind of talked about this up here, but this sounds cool too. Fetal risk include hypoxia caused by decreased uteroplacental blood flow. Medical treatment of this includes sedation aimed at stopping the contractions, promoting rest, and allowing a normal labor pattern to develop. So we're turning off that Pitocin immediately. We don't want any more contractions. Turning mom on the left side to stimulate more oxygen. We're giving oxygen and giving fluids as well. Now, a hypotonic labor, remember, this is also called a form of dystocia. Okay. Contractions are weaker than normal, irregular, and ineffective. Causes of this, risk factors of this are overstretched uterine fibers, maybe some twins, polyhydramnios, large baby, grand multiples, excessive analgesia, high anxiety levels, uterine abnormalities. Maybe they have some scarring. Maybe there's a tumor in there. Bladder or bowel distension. The mom could just be exhausted. Malnourished moms, or maybe preterm labor as well. We're giving some morphine to rest, and then later we're going to give an IV Pitocin to try to get things going back again. Artificial rupture membranes could be done as well. Get the body to release oxytocin. So we're going to be getting them to up and walk, getting some spicy foods, doing nipple stimulations, castor oil, or anything to release those prostaglandins. And I'll kind of read what it says here. Infrequent contractions with decreased intensity, that's what this is. This is more commonly occurring in the active phase of labor. Medical treatments within this include ruling out CPD and augmentation of labor or stimulation of contractions with oxytocin. All right, precipitous labor, a very fast labor that can cause more tissue damage. So a quick labor, like boom. Effects on the mom, we could have some tissue damage occurring, lots of anxiety and tension causing lack of contractions, increased risk of postpartum hemorrhage. For the effects on the baby too, this could be very harmful to their tissues as well. So it's important to treat the cause that could be doing this precipitous labor. All right, post-term pregnancy after 41 weeks. Why is this bad? The placenta essentially kind of stops working. Okay, so the placenta lasts a certain amount of time before it gets old and stops working, can have a decrease in the amniotic fluid. We have some complications related to big baby. Management of this, using an ultrasound to model that placenta kind of healthiness, maternal and fetal well-being, or we're just going to induce that labor. They'll be talking with their doctor and they're going to say, hey, if you don't, if nothing happens by the end of this week, let's get an induction. Problems with our baby here. We're going into fetal malpresentation or position. Need to know what is good, what is bad, and why. So the POP, posterior, occiput, posterior, the baby's head is facing their mom's back. Their lie would be longitudinal. Their presentation is vertex. This feels like more back pain. It's longer and a harder labor. Interventions to this are going to be helping our baby rotate by squatting and repositioning. Okay, with a brow, the lie is going to be longitudinal. The attitude is going to be extension. The effects of this can cause facial swelling in our baby and can result in a longer and harder labor. Intervention of this are going to be open that pelvis. I'm going to be taking a little break. Alrighty, I'm back, and let's add a little bit more to our brow presentation here. This is whenever the fetal forehead is the presenting part. 50% convert to vertex or face presentation, and the risks of this are a longer labor, possible C-section. Neonatal risks include facial edema, bruising, exaggerated molding of our head, increased risk of the cerebral and neck compression. Of course, damage to our neck areas, so our trachea and larynx as well. For a breech presentation, we've already talked about this in our 4Ps PowerPoint, but remember the types of breaches. We have a complete breach, we have a frank breach, and we have an incomplete breach. So a frank would be butt first. A single and double footling would be one or foot first. The lie could be longitudinal, and of course feet first as well. And effects, the cervix doesn't have to open all the way. We have a high risk for dystocia or cord prolapse as well. Whenever we have the breech presentation, we have some maternal risks that go along with that. We have a prolonged labor due to decreased pressure exerted by the breech on the cervix. We could have a premature rupture of membranes, which of course could lead us to getting some infection going on. We could have a need for a C-section or forceps delivery, trauma to the birth canal during delivery from manipulation and forceps to the fetal forehead. Alrighty. Then going into our shoulder presentation, their lie would be a transverse or oblique presentation, and the presenting part would be the acromion process. This is a definite C-section, and the goal would be to have a vertex or anterior, occiput anterior presentation. Alrighty, macrosomnia. This is a big baby. This is common in our diabetic mothers, or if they have a history of big babies. And often too, we have from our Asian cultures, we could have some, well, they're usually smaller as well. The effects our big baby equals big head. The head's going to come out, but it's so big that the shoulder can get stuck in the pubis. We could often have shoulder dystocia, which would make it really just a difficult process. We're going to have a long and hard work of labor. We're also going to have a risk of neonatal hypoglycemia because these babies, the reason they're really big is because they're eating so much sugar as well. So essentially, when they come out, that sugar is not going to be there. So really risk of hypoglycemia. We have trauma to our mom or a lack of oxygen for a baby that can lead to brain damage. We're going to do some management. We're going to the clavicle is needed to be moved to allow pass. So we're going to be doing the Macrosomia maneuver. We're going to take both legs and pull them back on our mom. Really, and applying that suprapubic pressure, okay? This rounds the back, tilts the pelvis, and this pushes down on their shoulder to push the baby out. And this could sadly result in a broken clavicle. So whenever they come out, and this is a newborn, this wouldn't be on this exam, but they're going to have an asymmetrical Mora reflex. We also have some placental problems here. I'm not going to say that S word, but not all the placenta comes out. We have a vasa previa. The baby compresses the placenta blood vessels. We have a velamentous cord insertion. The cord implants on the amniotic cord. Hemorrhage of baby. That's just pulled from the PowerPoints. We have a 2-vessel cord or a long and short cord. If it's long, we could have some twists and tangles. I imagine that Professor Hurl may have showed you that really concerning image during the PowerPoint. And then in the short, they could pull on the placenta when it comes down, which just would not be good. I mean, it would be, like pulling on a water hose and it's really tight. Here we have some definite signs as well. And really pay attention to these placenta accretas, incretas, and percretas. Make up something that would really help you memorize that. Remember, it's not too many words here. We're doing to the uterine wall, to the myometrium, and extending through the myometrium, okay? Maybe accreta, I would say, attaches increta into myometrium or invades myometrium, I'm sorry. And then percreta, just try to think of something. Really write those things out handwritten if that would help you memorize it. That's what I did whenever I took this class personally. And we also have a postpartum hemorrhage, which would be a bleeding, uterine atony, hypotension in bladder, of course, because they're pallor, because they're bleeding. We're going to be for care, IV fluids, uterine massages, legs elevated. We're going to empty their bladder, maybe with a Foley. Doing, of course, our meds and a blood transfusion, and doing not a quantified, we're going to be doing an estimated blood loss or a quantified loss. I forget which one's the more recent one, but we're counting. We're not going to be estimating now. So I guess quantified blood loss would be correct. All right, other problems, CPD, cephalopelvic disproportion, CPD. The baby just isn't fitting well, not good for our labor process. They can do some repositioning, IUPC, meds, and this can lead to C-section. We also have amniotic fluid embolus, and that I would refer to your PowerPoint for from class. Understand that is very fatal, not fatal, but it has a very bad rate of surviving, because that is just, just think of it as a fluid embolus or air emboli, just the difference between those. For non-reassuring tracing, please know the veal chop. That was last week's or 2 weeks ago content, but we'll be going over this within our exam prep sheets, okay? If you would like, take a little break right now. We're going to be getting into our questions here. All right, if you've come back, this is just really helpful for our questions. Which assessment finding would alert the nurse to be on the lookout for a possible placental abruption during labor? So think of a risk factor. In 3, 2, 1, it's going to be C. A woman gave birth to a newborn via vaginal birth with the use of a vacuum extractor. The nurse would be alert for a possible witch effect in the newborn. So think of it, the vacuum's going on the baby's head. What could be happening? C. A woman with a history of cocaine use. I'm not going to read all of that, but acute abdominal pain that is continuous. It's going to be uterine rupture. Okay, for the rationale of this, a uterine rupture is associated with a crack cocaine use disorder. Generally, the first and most reliable sign would be fetal distress, accompanied by acute abdominal pain, vaginal bleeding, hematuria, and irregular wall contour, and loss of station in the fetal presenting part. If we're talking about C, an amniotic fluid embolism often is manifested with a sudden onset of respiratory distress. For A, shoulder dystocia, this is noted whenever a fetal descent is obstructed after the fetal head is delivered. For the umbilical cord prolapse, this is noted as the protrusion of the cord alongside or head of the presenting part of the fetus. Okay, this is kind of taking us back to our Bishop score, knowing which is our best score, okay? So the answer for this is going to be A. The Bishop score often helps identify who's most likely to achieve a successful induction. The duration of labor is inversely correlated to the Bishop score. A score over 8 indicates a successful vaginal birth. Therefore, the woman with a Bishop score of 11 would have the greatest chance for success. A Bishop score of less than 6 usually indicates that a cervical ripening method should be used prior to induction. All right, next question. A nurse is conducting an in-service program for a group of labor and birth unit nurses about C-sections. The group demonstrates understanding when they identify which conditions as appropriate indications. This is the status, so I'll give it a little bit. Alrighty. So the answer for these are going to be, remember, active, A, B, previous, yes. If a previous C-section oftentimes is going to lead to a C-section, so that would be C as well. And then E, fetal distress, you know, when we're having some problems occurring, that's often associated. Dental thing. Okay, so the rationale of this is leading indications for C-sections are previous C-sections, breech presentations, dystocia, and fetal distress. Examples of specific indications include active genital herpes, fetal macrosomia, fetal pelvic disproportion, prolapsed cords, placental abnormalities, so they could be having placenta previa or placental abruption, or maybe a previous classic uterine incision or scar. Gestational hypertension, diabetes, and positive HIV status. Dystocia is often associated as well. Fetal indications include malpresentation, non-vertex presentation, congenital or abnormalities, fetal neural tube defects, hydrocephalus, abdominal wall defects, and fetal distress. A lot going on there. So I would rewind it, maybe write it down to help you understand really what's going on with the indications of a C-section. Okay, a pregnant client at 30 weeks gestation calls the clinic because she thinks she's in labor. To determine if the client is experiencing labor, what questions would the nurse ask? This is a SATA. So if you would go ahead and if you want to do this on your own, I would pause it right now. I'm about to say the answer. The answer is going to be A, B, C, and E. Okay. Let's read the rationale for this that we have here. Frequently, women are unaware that their uterine contractions, effacement, and dilation are occurring. This makes it really hard to intervene effectively in arresting the preterm labor and preventing the birth of a premature newborn. The nurse would ask about any signs and symptoms, being alert for the subtle symptoms of preterm labor, which can include a change or increase in vaginal discharge with mucus, water, or blood in it, pelvic pressure, a pushing down sensation, a low dull backache, maybe they're having some menstrual-like cramps, a UTI infection symptoms, feeling of pelvic pressure or fullness, gastrointestinal upset like some nausea, vomiting, and diarrhea. They could have a general sense of discomfort or unease, heaviness or aching in the thighs, uterine contractions with or without pain, or more than six contractions per hour, intestinal cramping with or without diarrhea. And the contractions also must be persistent, such that 4 contractions occur every 20 minutes or 8 contractions in an hour. And of course, if they're having heartburn, that's not related to preterm labor. But that is that. I'm going to be going back to I share the screen again. And if you wouldn't mind doing the attendance link above that we have here, if you haven't signed in already. And all right, thank you guys for coming. Remember, we're going to be doing our exam review next week, Wednesday the 13th at 6 p.m. I will be sending out the Zoom link, and please bring your what you have so far of our prep sheets as well. Okay. If you have any questions, please reach out. My email is going to be, it's actually changed a little bit, blake.montes@tmucc.edu. All right, thank you, and you'll have a great day. Bye-bye.